Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Harman Chawla. Dr. Chawla earned his medical degree at Bharati Vidyapith Medical College in India before completing his internal medicine residency at New York Medical College and Jamaica Hospital Medical Center. He completed a fellowship in geriatrics at Hackensack University Medical Center in New Jersey, followed by an infectious disease fellowship at Rutgers, New Jersey Medical School. Dr. Harman Chawla is board certified in internal medicine and geriatrics. Dr. Chawla is a member of the American Geriatric Society and the Infectious Disease Society of America. He is also a member of the Washington Township Medical Foundation.
Hello everybody, my name is Dr. Chawla. I'm one of the infectious disease, medicine and geriatric physician. I work with Washington Township. Okay, so the topic today which I'm going to talk about is aging and improving memory. So I'm sure everybody has asked these questions, and are you guys ever concerned about your memory? And do you ever get these questions in your head where you think, where did you put your keys, or where did I park my car, or do I even have a car? Do you rely more and more on these sticky notes? And have you getting problem remembering your appointment? Note it down and you don't make up or you forget. So if this is happening to you, or you're finding that the notes which you've made are just not enough, you check them off, but still you forget. So you need more and more reminders on your planner, on your phone. So if any of this thing is happening then to you, then this would be a good talk, or to your loved ones, if this is happening, then it'll be a good talk to be here for. So mainly the objective about the talk today is, first I'm going to just briefly go over some characteristics of aging. Then we're going to talk about medical assessment, how we can, assess for these cognitive impairment or dementias, and then what advice I can give you to improve your mental function. I think that'll be the third part would be the most important. So just a few points about aging. So the world population of adults over 65 is definitely on a rise, with all the baby boomers, getting older now, so it's on a rise. In US alone, currently there are 35 million people who are living over age of 65, and it is going to double. By 2030, it'll be 70 million. And by 2050, 1/5 of the world population would be over age 65. So geriatric, for a geriatrician, I think this is very good. Just briefly about normal aging. So with aging, our thinking process naturally slows down a bit. As we age, we do have trouble, with specific words. We have struggled, doing multitasking and face other minor limitations. But aging per se does not put you to risk for cognitive impairment. But however, with increased longevity, it has definitely led to a number of individuals with cognitive impairment at a greater number, including the basic, the Alzheimer's, which is, the most common form of dementia, and then the other forms, which I'm going to briefly touch base on. But it doesn't have effect on ADLs and IADLs. So ADLs, to let you know briefly, is activity of daily living. So that is just basic, if you just think about it, these includes, for you to, the time from when you get up, you go to the bathroom, you take a shower, you dress yourself, and you feed yourself, so that is ADL. Those are the basic ones, getting up from the bed up till, getting your breakfast, those are the basic ones. And then the IADL is a little bit more executive functions, anything from, making a phone call to, taking care of your bills or driving a car or, just taking care of finances. Those are all ideals, and including, what your spouse or your family or somebody else does for you, like laundry, washing, getting groceries. Even all those are ideals. So those require a little bit of higher executive function. With normal aging, both of these don't usually get affected. A step up, which is a mild cognitive impairment. When you have these mild cognitive impairment, you do have changing in thinking ability, but it's usually not noticeable to the person itself, but it'll be noticeable to the family member or a friend or a loved one. And it does not affect the ability to carry out ADLs. Again, ADLs and IADLs and this mild cognitive impairment would not be affected as well. But in some cases, this mild cognitive impairment will be, will mimic like an early dementia, but it usually not always leads to dementia. And then sometimes if you do have this mild cognitive impairment, it will revert back to normal. Just to go a little bit more advanced, then you have this dementia. So dementia, most common form is the Alzheimer's, and the Alzheimer's Association terms dementia as a general term where there is a decreased ability which is severe enough now to interfere with one of your activity of daily living. So once you get into that, where you can't do your basic or more IADLs will be affected first, where you can't take care of financing, you can't do your laundry and other stuff. So that goes to form where now you are into that dementia threshold. And that is usually more progressive and disabling. And out of all the dementias, the most common form is the Alzheimer's dementia, which accounts for close to 60 to 80% of dementias. And with this also you have difficulty in conversations, you'll have remembering names. And these are usually, when you have problems doing this, would be early symptoms. It can also lead to, like, if you can't remember stuff and that bothers you, and that will lead to apathy, and it'll also lead to depression. And those also are usually the early symptoms of dementia. But once you progress into late onset dementia, the later symptoms, this will impair you, where you will be having problem in making conversation, there'll be more disorientation. It can also lead to confusion and some memory changes or behavioral changes, where you'll be more hyperactive, or you'll get something called the sundowning, where when towards the end of the day people get more confused. So some of these symptoms would be later onset, but the early ones would be just remembering names or recent conversation. The Alzheimer's disease is currently on a rise as well. There were 4 million cases in US, but it's 2012 numbers. It's estimated to be close to 10 million in 2050, and this is also because of increase in longevity. There's certain risk factors which can cause dementia. The most common is aging, with longevity going up. The second is family history. Again, the family history part is there's some genetic linkage to this where the dementia can occur, but there is not enough studies to say that family history is really, which is an attributable factor. Then head injury is one of the big factors. If as a kid, or as a teenager, if you've played too much of contact sports, or if you were in a car accident, or if you have recurrent falls, then you lead to this concussions, which will cause impairment of the neurons, and that will lead to dementia. Fewer years of education is also one of the risk factors. With education, or if you're not using your neurons as much, it can lead to dementia. Female gender is also related. One, because estrogen has an effect, safety effect on dementia, and as you approach menopause, the estrogen level goes down, and that then you become predisposed to dementia. And obviously we all know that females outlive men by far. So once they get older, they are the age which they get older than men, so they are more prone to dementia. Genetics do play a linkage. So from this you can have some family correlation, family history. So if you have mutation in this chromosome 1, 14, or 21, 21 is the one which leads to Down syndrome. So if there is some correlation, or if a family member or a first degree, especially if a first degree relative has any of these mutations, including Down syndrome, then there's a risk factor of having dementia. And then this apoprotein E, this is a protein which is on chromosome 19. If there's a mutation of this, then there is an association with a late onset dementia. The other ones, which is the 14 and the 21 with down, there's early, where dementia will occur quicker around age of before 60 as well. Then there's some protective factors as well. Vitamin B12 is one of the big one, which is easily correctable. It is one of the essential vitamin for our nervous system. So if you are deficient in vitamin B12, if you replenish it, there have been some proof that it'll, prolong mild cognitive impairment. Then the big one, other one is antioxidants. There's been a lot of studies because antioxidants have protected effect on our neurons. So if you eat, again with fruits, we'll have it. Any kind of berries, raspberry, blueberry, strawberries, all berries have a higher antioxidant. Wine, especially red wine, so if you want to drink a glass of wine, that will have a lot of antioxidants. And then antioxidant has another effect because it has a protective effect like it has it on our heart. It prevents atherosclerosis or clogging of our vessels of our heart. It also prevents clogging in our brain, and you're less prone to getting strokes or vascular related dementias. Statin, again, similar, like I explained to antioxidant, like it's protective for our heart, it is also protective for the brain as well. It prevents, strokes and vascular form of dementia. Physical activity is also another big one. It increases blood supply to all over our body, so it increases blood supply to our brain, so the brain keeps regenerating. And then intellectual activity is like, if you're doing any kind of, reading, if you're keeping up to date, you want to learn an instrument, you're doing crossword puzzles, anything which is, stimulating your brain, I think will, help with it will be a protective factor, and I'll go over some more stuff. Just differential diagnosis of dementia, this is more for the physicians, but I think just to quickly touch base, normal aging and mild cognitive impairment we discussed. Delirium is a form of dementia which is reversible. It's a waxing and waning form of altered mental status where any kind of illness will cause this. And there's a little bit of overlap between the mild cognitive impairment and the delirium. A lot of medications will do it. Any kind of cold remedy medication, Benadryl, any kind of some medicines which you use for heart, which has this anticholinergic side effects, will cause you to have this delirium. But delirium, the good thing is it's reversible. So if you have any infection, if you treat it, you'll revert back to normal, and it usually doesn't affect or predispose you to getting dementia, but it's just a waxing or waning effect. Then depression or bereavement is one of the big differential, and it's also reversible. So if somebody is depressed and you can treat them with antidepressant or other medication, or if you can take care of the stressors, or you can have good support system, or if you work in a support group, if your depression is corrected, then the social withdrawal part will improve, and and then sometimes you will have overlapping symptoms with dementia and it'll get better. Then Alzheimer's I'm going to talk about. Then the other one is vascular dementia, which is associated with strokes, or if you have like a mild transient TIA, it's called transient ischemic event, where you have some memory impairment and then it gets better. So with this is also not reversible though. If you have recurrent stroke, then you can be more predisposed to getting dementia. And the vascular dementia, how we differentiate from Alzheimer's dementia is very slow progressing. It's like a graph, it's like a linear graph. We slowly progress into, dementia. But the vascular dementia is all of a sudden. So if you have a stroke, you'll lose your neurons, you'll lose your memory, and it's like a stepwise where you progress more quickly. So it's a stepwise memory loss, and it's more progressive. Compared to Alzheimer's, which is slower and it's a linear form. And then there are a few other forms of dementia, which are associated. The big one is alcohol. If you drink, a lot of alcohol, that will affect your neurons, and it will, break those synapses in the brain, and you will be more prone to. So alcohol is some association has. And then Parkinson, if you have Parkinson disease, there's a Parkinson disease-related dementia, and those you will have other symptoms where, you'll have rigidity, you'll have like, pill-rolling tremors, so those ones. And then the other one is the pig disease, which is frontal. So our frontal brain is one which helps us processing. So if the frontal lobe has a stroke or an infarct, then that can also cause dementia. Lastly, is neurosyphilis. Again, this is correctable. Syphilis, if you have been exposed and if you treat, again, it'll slow down the process. The last one, which I didn't put in, is called hydrocephalus. It's called normal pressure hydrocephalus, where you have, it's like a triad of symptoms. You will have gait imbalance, you'll have dementia, and then if somebody has incontinence. So if you have this triad of symptoms, then we can have your primary doctor, or you can see a neurologist. They can do a CAT scan of your head to see if there is any dilatation or of your ventricle. So our brain has the brain tissue, and then it has a fluid which is called ventricle. So if that increases, then the normal brain parenchyma shrinks, and then you will have these triad of symptoms. So those are like a pickup signs, and then your primary doctor can test you with a CAT scan to look for it. Now I'm going to go into assessment of an older individual. So the aim which we use this assessment is to promote wellness and independence. And then we usually focus on function and performance, where your gait, your balance, and the transfer going from one place to one other place is improved. The components which we mainly look into is physical, then cognitive and psychological and social. And then approach is usually multidisciplinary, where different social services, your physician, support group, everybody comes together to help. And then outcome is mainly to maintain and improve quality of life. Now, just to go briefly on physical assessment, I'm going to touch 4 of these components here. First would be functional status, nutrition, vision, and hearing. So the functional status, which we briefly discussed, these were those ADLs and IADLs. So these ADLs and IADLs usually doesn't get affected with aging or mild cognitive impairment or with delirium, but with your dementia, when you are early or late, or when you go into that form, then these get affected. So again, just to go, activity of daily living would be anything from getting up in the morning, transferring yourself, going to the toilet, grooming yourself, then bathing, grooming, dressing up, and then feeding. So this is the basic, from morning when you get up to taking your breakfast. Those are the main activity of daily living. Then the instrumental activity of daily living, which I mentioned, was a little bit more higher cognitive function, which includes, making a telephone call, preparing your meal, managing finances, taking your medication, doing laundry, household work, household chores, shopping, and then transportation and driving. And then also the function status, which your physician can assess, is through this test. It's a basic test. It's called Get Up and Go test, where the physician will request you to, from a sitting position, unassisted, get up, walk at least 3 feet, turn around and walk that 3 feet back, and sit on the chair back again. And normally this should be completed within 30 seconds. So 20 to 30 seconds, but definitely less than 30 seconds. But if it's more than 30 seconds, then there's more predisposition for a person to fall. So if you do more than 30 seconds, so risk for falling is more, and instability. The nutritional status, this can reflect a medical illness, it can reflect depression, your functional loss, or financial hardship. And usually a physician will look into this by doing body mass index. This is your weight in kg divided by height in meters square. So a low BMI, which is less than 20, is a risk factor for malnutrition. And then for the person itself, or for you guys also to watch for this unintentional weight loss. If you have weight loss more than 10 pounds in 6 months, that is unintentional weight loss. And then you should talk to your doctor or to your physician about it. And then vision is also important, and these are the few things which you have to assess. One is cataract, glaucoma, macular degeneration, or abnormality in accommodation, which means abnormality in focusing. And a physician can ask you about if you have any problem doing this everyday task like driving, watching television, reading a book. And then we have these performance-based testing where physician might ask you to read a newspaper or a magazine aloud when you go for a visit, to the point where they're sending you to the ophthalmologist for a dilated eye exam and to look into it. Hearing loss is also common in adults. Hearing impairment can lead to this depression and social withdrawal, and then somebody will think that that's cognitive impairment, but it's fixable. And the most common is just as simple as wax impaction. And if you treat that, or if you take care of that and they hear better, they'll be more socially involved. And then exam after that could be done with a handheld device, which your primary doctor can do it to the and also they can send you to an ENT if they feel, and they can do an official audiometry testing to hear that. Now, why to screen for these cognitive losses? Because most people with dementia do not complain of memory losses. And as cognitive impaired, older person, they are more risk for accidents, fall, medical non-adherence and disabilities. So if we screen them early and if this can be halted, then some of these late complication or other stuff associated can be prevented. Now, this is the test which we were talking, for cognitive impairment, which can be simple as, just doing a 3-item recall test where your physician will tell you to, just remember 3 things. I've just put this apple table penny. So if you memorize this won't, you won't pass the test, but they might give you something else, but something like that. And then if you can't recall that back in 2 minutes or 5 minutes time, then, it predisposes you to, get further testing. So the further testing would be, just a basic clock drawing test where your doctor will help you, ask you make a clock. It's a round clock and they'll put numbers in it, and then they'll ask you to put a time, and they usually use like 2 half of the clocks, like 9:30 or 15 minutes to 3, something like that. They'll ask you, and if you can't draw that clock and if you can't put the hands of the clock, then those will also trigger them to do further testing. And the third test would be just to name 4-legged animals in 1 minute, and you should at least be able to name 8 animals in that 1 minute, 8 to 10. So if you can't name 10 animals 4-legged in 1 minute, then again will prompt your physician to do further memory testing. And the further memory testing which I wanted to mention was this mini mental status examination. This is the most common test which is used after the basic questioning, which was in the previous slide. And this would test more stuff as well, like orientation, registration, recall, attention, calculation, and language. And if the score is less than 24, this would again warrant for other testing, like imaging or any CAT scans, or look for other medical problems. And the score usually 21 to 20, anything over 24 is okay. Less than 24, 21 to 24 is mild cognitive impairment. And the good thing about this test is, I'm going to show you the chart which I put up in the next slide. But the good thing about this test is, one, it'll test for all this stuff, orientation, registration, recall, but also it helps us to gauge, if there'll be progression into other stages, or it'll also help us to decide what kind of modalities we can use. If it's just mild, then maybe just something like non-pharmacological management, where you can join the support groups or stuff, versus just using a medication, using one medication, versus if it's goes to the moderate form, then using 2 medication, or one which is stronger medication, which I'll go over, or if it's severe, then combining these medication with other modalities. So this helps us. So this is the test I just put, just to go briefly. So the orientation part, each thing has a point. So if you can name year, season, date, day, and month, so you get 5 points. State, country, town, where you are in hospital, what floor. If you are seeing your physician, what floor is his office. To registration, where he'll ask you, give you 3 objects, and he'll want you to recall it after some time. To attention and calculation, which is called the serial 7, where he'll ask you to count back 7. You have to divide. You have to minus 7 from 100, and go back. So like 9386, they'll have you do that, or spell world, WORLD backwards, and then you get a points for that, to recall where you've the previous objects he had shown you will ask you to recall after some time. And language includes name or object, repeat a sentence, or three stage commands where they'll ask you to do like something like this can be changed, this can be different as well, but the basic one is take a paper in your hand, fold it, put it on a table, three-step command where you have to do those, or write a sentence or draw a design, any of these. So this was out of 30, and whatever score you get out of 30, we can gauge which level you are and what kind of treatment modalities will be ideal. Also to assess for psychological status, because major depression or bereavement sometimes can mimic, or sometimes it can be subclinical where a person might not feel it. So the basic screening question which you can ask, or your physician might ask, do you often feel sad or depressed, something like that. And then they have geriatric depression scale, which is also similar to the ones which I just showed you. It's a questionnaire which they go and you get points, and they can assess if you're depressed and if you need any medication or correct the underlying cause. Now the primary goal of treatment here is to enhance quality of life and functional status by improving cognition, mood, and behavior. So initially, we always like to try non-pharmacological management, or if it's early form, we can try this with individual or group therapy, and then something like, just having regular appointment with your physician or your psychologist, and they can just take care of your medical problems. If the medical problems are taken care of, then like your dementia, if you have depression, if you have diabetes, hypertension, if those all are under control, then it predisposes less to go into cognitive impairment. And then just communication with family members, caregivers, friends, environmental modification, where you live in, somewhere where there's regular activities which is done, like assisted living, where they have like more interaction, so you're not living on your own or living with your family, friends, basic modification. And attention to safety as well, safety meaning, your houses, not like baby proof, but it's proof in the sense, you don't have rugs, carpets, you don't have too slippery floors where you can fall or stuff. So just taking care of that. Now the pharmacological management is this cholinesterase inhibitor, which is called donepezil, which is the most common medication which helps to improve central nervous function. So this is one of the basic ones. So if you are, if you do that many mental status, and if you are in mild to moderate going towards that, then with the other non-pharmacological management, you can have this adjunctive therapy. So those non-pharmacological management you have to do with everybody. Plus you can combine one of the medication, which is this one, and then the other one is called memantine, which is a little bit more potent, which helps in memory, attention, reasoning, language. This usually is used when you're going into moderate to severe, or it can be used as an add-on with the donepezil. Then the other cognitive enhancer are estrogen. These are used in anecdotal cases. They're not actively prescribed, but estrogen, like I said, has a preventative effect. So if you use that, same with aspirin and NSAID, like Motrin, Tylenol has some effect. Some herbal medication like ginkgo has it, and then vitamin E and vitamin B12. Sorry, I didn't put that. Vitamin B12 also has a big one. Then treating the other accompanying and mimicking problems, antidepressant for depression. The other thing would be to, like I said, it should be multidisciplinary and referral to, specialty services, including social worker, physical therapist, so that if you have history of falls, just to get you up and about and get you strong physically. A visiting nurse or a home health aide, if you need some help initially, can come. And then also to referral to specialty services, including psychiatrists if you have any underlying problem, or neurologist if there's anything correctable like dementia, like strokes or stuff. And then a neuropsychologist, who can just be, talk to you and, just to help you with that. And many of these services are covered with Medicare, for you to know. Now, this would be the most important aspect of our talks. So the basic tip, is just to stay mentally active and to do mentally stimulating activity, just like crossword puzzle in your newspaper, or doing a Sudoku, reading your section of newspaper, whatever interest you have in there. Taking an alternate route to go to your home or for your appointments. Avoid using navigation because you're just getting dependent on it. Learn to play a new instrument, or if you want to learn singing or music, whatever, which you all have wanted to do, and if you have time to do now, would help to stimulate, and to volunteer, at a local school or in a community service or in an organization or hospital. This has helped with few of my patients, downloading these cognitive games like Luminosity. A lot of patients have this Luminosity, they have there on their smartphones. And a few other ones are like Elevate and Mind Game Pro. Works in a similar way, but this Luminosity and Elevate are really good. So socialize with your loved ones and friends. And then a social interaction, helps ward off depression and stress. So if you don't have enough stress, then, in turn, you would feel better, and, you won't have this cognitive impairment or mild cognitive impairment. And then organizing yourself. This is also very important. So if you're likely to forget things if your home is more cluttered. And then it's important to jot down tasks, appointments, have a notebook, calendar, a planner, put stuff in there, have reminders would be helpful. And then to keep to-do list current, so if you've done something, check it off so that, you don't keep reading it, or just take it out of your, smartphones if you're using a planner. And then set aside, certain places, there's certain place where you'll always keep your wallet, you'll put your keys and other essential, so that, you reflexly go there and you don't have to look for it, and that stresses you. You have to focus, limit distraction, don't do too many things at once. Focus on the information which you're trying to remember, and then you definitely recall it later. And then you can connect, some familiar concept, you can connect some favorite song, and you can relate that so that, you remember it. Eating healthy is very important. So this is where, if you're eating fruits, if you eat vegetables, whole grains, eating low-fat proteins. Now, proteins is very important because you need proteins to form these, components of your brain cells. You need proteins, healthy proteins, and then to get it through fish, lean meat, and poultry. And then also, if you eat proteins, and each meal technically should have a protein, not just one meal should have protein, each meal should have. And then it also helps you to fight infections as well. You need proteins to form antibodies. Proteins are the integral form of that. So if you eat proteins, you will fight infections. You won't get delirium. You won't get, delirium. Once you get, then you can have cognitive impairment. So it's like a vicious cycle. And then eating heart-healthy diet is also good for brain. Like it's protective for your heart, it's protective for your brain as well. And drinking do count as well. So, you need to drink water. So you're drinking good amount of water, and to avoid a lot of alcohol. If you're drinking a glass of wine every day, that's fine, because that has antioxidant. But, drinking too much will cause, memory impairment and loss of these neurons. Physical activity, again, like I said, it helps you to have blood flow throughout your body. So it'll help blood flow to the brain, and it'll keep your memory sharp and your brain sharp. And then American Cardiac Association recommends at least 150 minutes of moderate aerobic exercise, which includes brisk walking. At least you have to do 30 minutes of that every day, at least 5 days a week, or 75 minutes of vigorous aerobic exercise, like jogging, swimming, or using treadmill or elliptical. I tell this to my patients, you can use this fitness tracker, like a Fitbit or a Garmin. Fitbit is, it's easy, you can put it on your hand. You can use it with your, loved one, with your spouse. You can, challenge each other to see how much you are moving about, how much you're walking, and then you can set aside a goal. Okay, today I did this much steps. And then managing chronic problems, such as your diabetes, high blood pressure, depression. If your doctors is managing and you're on top of it, then you less predisposing yourself to getting mild cognitive impairment. And and always to discuss your medication with your physician. And then you can have something called, as I like to do this with my patients, called brown bag visit, where I tell them to bring all their medication, over the counter, herbal medication, and we go over all those medications to see, and we review that, and to see if some medication we can cut down, because polypharmacy, if you're taking too many medication, will have drug interaction, and those will also affect the memory. Now, Medicare has set this wellness visit, and they do this screening for this cognitive impairment. It usually begins at 65 because that's when we get Medicare. Obviously, if there's a concern that you're having memory lapses or memory loss, then this can be done early, and you just start with those basic tests first, and then you go into the mini mental, which gives us a score. The problem is the current treatment may delay, so the medication and with non-pharmacological they can prevent the further decline, because cognitive, like I said, Alzheimer's is more slow progression, so it will decline it with the current medication, and it also will help to improve quality of life for the patient and the caregiver. But unfortunately, with these current medication and they don't cure. There are some other stuff or treatments in pipeline which are coming up, still not approved. Something as using monoclonal antibodies which targets because we form antibodies or stuff to our memory cells, so they just target those specific antibodies, and something like which we use for rheumatoid arthritis or for lupus. The Humira or the Enbrel or whatever those ads which come, which are monoclonal, which targets antibodies, which attacks these specific kind of cells, in our joints or in lupus in our in our blood system. So they are trying to come up with these antibodies or monoclonal antibodies which targets exactly those those cells in our brain which destroy these memory cells. So they're trying to come up with that. The other ones are they're trying to do like recombinant studies where they're modifying these viruses, and then they've used it in mice where they inject back into the mice, and then to see if that in turn protects the brain cells. But again, this is like playing with nature. So if I have to tell you which is coming up, I won't go into this this genetic modification. If there is, I would be very skeptical in using those medication. But those monoclonal antibodies, if they can form or they can specifically target those antibodies which affects our memory cell, would be like life changing. Thank you. Thank you.